Hello, thank you for joining us for what I hope will be an interesting and informative discussion around some of the latest data in rheumatology. My name is Professor Peter Nash from Griffith University in beautiful downtown Brisbane in Australia. And today I'm delighted to be joined by Dr. Alsakarneh, internal medicine resident at the University of Missouri, Kansas City in the US. Welcome. Thanks very much for giving up your time to be with us. And we're going to be discussing your recent paper, which is looking at de novo inflammatory bowel disease in patients with psoriasis and psoriatic arthritis treated with IL-17 inhibitors. And it's a population-based study. And it's recently been published in a journal that I don't really follow very closely, Elementary Pharmacology and Therapeutics. But it's quite an important issue, and we've got plenty to discuss. So welcome. Thanks for your time. And can you just give us a little bit of background about yourself? Where you're from, where you're working, what your interests are?
Yeah, sure thing. Thank you so much for hosting me. It's a pleasure being here. Again, my name is Saqr. I'm originally from Jordan. I'm doing my residency here at University of Missouri, Kansas City in the United States, where I am also today is actually my graduation from the master's degree, where I did my master's of bioinformatics with emphasis on clinical research. I have a special interest in GI and particularly IBD and PSC, where I do my most of my research. This July, actually, I'm moving to Mayo Clinic in Minnesota to start my GI fellowship. So this is a little bit of background about me. And again, thanks for having me.
So that's great. So let's look at this issue because the IL-17 inhibitors are quite popular because of a number of reasons in the rheumatic diseases. The use is being expanded. For example, giant cell arteritis, polymyalgia, all these things are coming. And we now have 7 of them, including 2 nanobodies. And not only blocking IL-17A, we're now blocking A and F. And so it's a very topical paper because apart from some minor candidiasis that's easy to cope with, the question of inflammatory bowel disease induction and reactivation of those with a history is particularly important. So why did you decide to do this particular study?
Yeah, well, as you just rightly mentioned, this is, I think, pretty important topic for any patient with psoriasis, psoriatic arthritis, or ankylosing spondylitis starting these medications. Again, this is, I think, popular medication among these patients, very effective, relatively safe. That's why we see it a lot being and given to these patients. So I'm actually being mentored by Dr. Ferry. He's from Mayo Clinic in Florida, and we were in one of the conferences called ACG, American College of Gastroenterology, and we've noticed that there were a lot of case reports about flare-ups or de novo IBD in patients with psoriasis or psoriatic arthritis being treated with one of these medications. We went to the literature. There were no, there were a lot of like case reports, but there were no large studies on that topic. And this kind of studies, you need large population to study this. So um, the idea, I think, started from there, from these case reports, from the importance, and in the clinical practice, when I did some of my clinics in the IBD clinic, we've seen this. We've seen patients treated with psoriasis or psoriatic arthritis and had flare-ups or a new IBD. So this is the origin of the idea. So we went ahead and we conducted this study, which showed what's in the literature.
Yes, excellent, excellent. So now let's talk a little bit about your methods. So you use the TriNetX platform, which gives you access to 67 healthcare organizations and 120 million patients. Tell us a little bit about it. How accurate is the diagnosis, and how do they get around things like selection bias? Everyone knows particularly the rheumatologists know the IBD issue. So that tends to track patients at high risk away from or towards this and that. So just give us a bit of a feel about how much we can trust the TriNetX platform.
Yeah, no, I think this is very great question for anybody who would critique or read the paper. Like, is this accurate since it's a population-based study? So let me start by saying this. Part of my master, there was a course where we study about population-based studies or big data. So there was a paper, very popular paper published, I think, in 2007 in the American Journal of Statistics, I think the name of the journal, basically saying that for rare diseases or rare conditions or rare risk factors, the best way to study them is to look at population-based study. And that is because of a couple of reasons. And first, you need large numbers. And these large numbers usually remove bias, you know. So how accurate Trinetics? So Trinetics is getting more popular these days. And basically, it is a platform. It's in the United States, and there is some of it. It gets data from other European countries, so it's basically international. But in our study, we looked at the U.S. collaborative network and Trinetics. So it is basically depend on somewhat natural language processing, where it extracts data from EMRs or EHR, electronic health records. Um, and it depends basically on coding. So, what we did in our study, we looked at patients who got the diagnosis of psoriasis, psoriatic arthritis, etc., through coding. And again, as a physician, you know that there is bias, as you said, selecting bias, and not all of these diagnoses are accurate, of course. So there were no way to 100% to prove all of these had patients had psoriasis or psoriatic arthritis. However, as in our methodology, we made sure to do a couple of things that would increase the sensitivity and specificity of our study, such as making sure that the patient who received the diagnosis of psoriasis or psoriatic arthritis had this medication, two prescriptions 6 months apart, meaning that they were really not only diagnosed and got one prescription, they got two prescription, meaning that the medication were approved by their insurance and got these pharmacy claims. So we've done out of, I think, pretty more than like 10 to 20 papers recently in the past couple of months on this database. And I would say it's really a trustworthy database.
Okay, excellent, excellent. Now, are you able to pick a history of IBD going on to these drugs or never had IBD going on to these drugs?
Oh, excellent question. Any patient who included in the study never had history of IBD. Anyone with history of IBD were excluded. So we started with zero IBD and 100% psoriasis, psoriatic arthritis patient, ankylosing spondylitis patient. Then we followed them.
Okay, excellent. And you did have big numbers, but to be fair, at the time you did your study, you didn't have bimekizumab data, you didn't have brodalumab data, you had ixekizumab and secukinumab, but you did look at 13,000 patients in the IL-17 cohort, and you did look at tell us a little bit about how you defined them and what this propensity score matching helps you with, because I don't know what nearest neighbor greedy matching is.
Yeah, no, sure thing. So basically, we started, as I said, by extracting patients with psoriasis, psoriatic arthritis, all forms of psoriasis, basically, and ankylosing spondylitis through ICD-10 codes. Then, what we did, we made sure this patient received again one of these two medications, secukinumab or XC, for two prescriptions 6 months apart to make sure they receive the medication. So this was our patient population. And
How long did you follow them for?
yeah, excellent. So we started from 2015, which is the FDA approval of these medications for psoriasis in the United
Hmm.
States. That was the study period, and the end was 2024, December
Okay.
2024.
Okay.
And we selected a comparator group or a control group. And this control group, as you know, we needed this patient to be same severity, uh, because same severity means they are both at same risk of IBD. That's what literature say. Moderate to severe psoriasis, they're at a higher risk of IBD. So we had another control group who received a Prevlimast um, uh, therapy because this medication has been shown in the literature. There were only second phase clinical trials on this medication that showed its some efficacy in IBD, but no um, uh, third phase phase 3 studies were conducted. So we had this control group, and then to make sure these two population or of the study are comparable, we have to match them. You know, when you want to do clinical trial, you do matching to remove bias and confounding, etc. So that was our goal, is to match these two group to remove or to minimize confounders between both. So we use what we call propensity score matching, one-to-one propensity score matching, basically to match these two population based on a pre-specified confounders. And the confounders we use like age, sex, demographics, severity of disease, history of use of other IBD medications, history of other autoimmune diseases. It's an extensive list that has been shown to have to be like a confounder an IBD risk. So we matched both the group to be comparable and have the same risk of all these confounders to minimize confounders. And we conducted then the analysis using Kaplan-Meier curves and Kaplan-Meier analysis, reporting hazardous ratios. And we reported adjusted hazardous ratio, meaning that any value we presented, it's after matching, after these two population were matched and we have same population numbers or sample in both groups.
Okay. And did you have an idea of the expected incidence in the untreated person with psoriasis, psoriatic arthritis, or ankylosing spondylitis?
Honestly, we didn't have any idea except the literature. Before that, we didn't expect anything. But after the analysis, I think the it was 0.45% in patient not treated with IL-17A inhibitors and 1.05% in patient treated with IL-17A inhibitors. And that was again after matching.
Okay, excellent. So tell us a little bit about your results. I still want to know what greedy matching is, but that's okay. Tell us a bit about, tell a bit about your findings, the hazard ratios, the number needed to harm, and whether there was any predictors and any real difference between the two 17s.
Yeah, sure thing. Just for the nearest greedy matching, this is part of the analysis for propensity score matching. That's it. So for our results and outcomes, so basically, as you rightly mentioned, we had 15,599 patients in the IL-17 group and 22,000 in the non-IL-17 groups. Then after matching, we got 13,216 in both groups. So this is our sample we started with. So again, the risk in the IL-17 inhibitor, we had 142 patients, which equals to 1.07% of these patients developed IBD, compared to 60 patients in the other group developed IBD, which equals to 0.45% in the control group. The adjusted hazardous ratio was 2.5, and that was statistically significant. So again, the anti-IL-17A cohort had a higher risk of IBD than the control group. The number needed to harm was 161 from like in the IL-17 inhibitor. So basically that means if we had 161 patients starting the medication, one of them could develop IBD. So also we did a subgroup analysis to know the risk of Crohn's disease and ulcerative colitis, the two most common forms of IBD, and both were at elevated risk, these patients, and particularly Crohn's disease was higher risk at 3.95 adjusted hazard ratio, which is pretty high. And the ulcerative colitis was also statistically significant. Adjusted hazard ratio was almost 1.8. We went ahead to know the predictors, as you rightly mentioned. So we did multiple subgroup analysis, and one of the most important is the A subgroup. So we did multiple A subgroups, and the highest risk was actually in patients above 60 years. So patient above 60 years old, they had a risk of 3.3, and again that was statistically significant. The adjusted hazard ratio was statistically significant. Also, both male and female were at a high risk of developing IBD, but again, when we did a subgroup analysis for those who developed, you see there was no statistically significant in male or female of this subgroup. And we think that is because this very, very narrow subgroup was due to mainly low sample number. The most important, I think, subgroup we did, secondary analysis we did, and the highlight, I think, of the study, when we did both medication separate, we found that secukinumab was associated with higher risk of IBD with adjusted hazard ratio of 2.8. However, patients who were started on ixekizumab, they did not have a statistically significant increased risk. And I think we're gonna come later and explain why we think these are the results.
Okay. And was there a difference between incidence of either Crohn's or UC, psoriasis versus psoriatic arthritis versus angst?
Yeah,
Because in our literature, the AS is higher than the PSA, which is higher than the PSO.
right. Unfortunately, we did not conduct a separate analysis for like AS, psoriasis alone, or ankylosing spondylitis. We made them as one group who started these medications. We matched them both, and we went ahead with the analysis.
And ICSI came to the market much later than SECU. So is it that one group was on a drug for 1 year and the other group for 5 years? Is there a difference that would affect your hazard ratio? And what was the kind of mean time to develop disease? Was it time related or just at any time?
Excellent, excellent. So again, I think we have the same way of thinking of why ixekizumab, they had lower risk, and we thought the same because it came back later. So physicians were aware of the risk of IBD. So the patient population they would prescribe these medications to are totally different. Meaning that if I had a patient with psoriasis come into my clinic, I want to start them on IL-17, I would be hesitant to start them on ixekizumab because I know this medication could predispose them to IBD, and I would go to another category of medication because, again, we had the experience from the ixekizumab for a long time. And so as we used Kaplan-Meier curves, I think that would balance the two groups, meaning that we wouldn't have patient only looked at for 1 year and the other would looked at like for 5 years and they had more time. No, we had these curves using adjusted hazardous ratio using these curves time to event. That's why you use this. So we use time to event analysis instead of odds ratio or something like this to account for the time patient use the medication. And again, for your question, the meantime, how long the patient use the medication, I don't have it on top of my head, but the most important I remember is both groups, the IL-17 inhibitor and the control, they had same mean time of using the medication.
I mean, time to event of the IBD, is there any clues? Did it come on in the first year, second year, third year? How long is it take to develop it if you're going to? Is it purely random or does it take a couple of years and then it increases?
Yeah, it's purely random. Some patients would have it like a couple of months after starting the medication, and some developed IBD maybe 7 years after that.
Okay. So you said male sex seemed to be higher. You said over 60 seems to be higher. If I read the table two correctly, what about steroid use? What about, or not table two, table one, steroid use, NSAID use, any other predictors that we could think about?
Yeah, we mainly use these medications and characteristic to adjust for confounders and to balance the two groups. And again, due to low sample numbers, we did not conduct further analysis based on these predictors.
Yeah. So, do you think the difference between SECU and ICSI is real or a quirk of the numbers and the time to market, and that a proper prospective study is the only way to show any real difference?
Yeah, again, I agree with you about the marketing. So it came later, and again, physicians maybe were more aware of the problem, and they avoided prescribing these medications to patients who are at like predisposed to IBD, or they have family history of IBD, or they have signs of other inflammatory disease that would predispose them to IBD. So I think marketing was really a big problem for that. And I think, again, I don't think we can do like RCT on this topic, right? But again, I think more prospective studies would give us a clearer idea. But again, searching the literature, we don't have anything that I would very scientific to base our result or to interpret them in the context. Why is that in terms of pharmacokinetics or pharmacokinetic standpoint? However, the other medication we really wanna see its result is the pimikizumab. However, unfortunately, there were low numbers, and the reason really for that because both of these medications we did our analysis on target IL-17A. However, the other medication also target both the IL-17A and IL-17F. And if you look at uh, if this medication block both, that might actually in a way or another, these patients would avoid the exacerbation or new onset of IBD because you're blocking both of them.
Right? And any take-home messages for the practicing clinician?
Yeah, this is very important. I think the it's the cream of our study is to say that any patient who would be starting this medication first, we have to conduct a full history, looking at any hints if these patients are at high risk of developing IBD. Second, maybe getting fecal calprotectin, looking if it's high, maybe it's better to avoid this medication because these patients at high risk of IBD and a patient with family history also of IBD to weigh the benefits and risk before starting these medications.
Okay, so we clinicians do it very differently to that. In fact, we only do calprotectin on people with symptoms, and we take it easy on patients with a history, but not people who have no history of IBD. Can you give us, and this is the key that the patient will ask, all you've really shown is that a drug that isn't associated with IBD causes it less often than drugs that can be, but then we have to put it in absolute risk. We've been taught from the clinical trials that for psoriatic arthritis, the risk is 1 in 1,000 per year. And with Agspond, it's something like 5 to 7 per 1,000 per year. From your study, do you have a feel for what kind of absolute risk I can tell my patient? Is it 1%? Is it 0.5%? What's your what does this study help us? Absolute risk de novo for a patient starting on medication.
Well, I think the only thing I can tell from this study and evidence-based, I would say, and the numbers showed is the risk we've in our results, which is around 1% of these patients, and number needed to harm is 161. This is the only evidence-based we can tell. I don't have absolute risk of I can tell about the risk of IBD starting I-17A, except what we have in the results.
Okay, we thank you very much for your time. Where are you going to go with the research next, or are you moving on to other issues?
Yeah, I'm starting in July my fellowship in Mayo Clinic for GI, and again my area of interest is PSC, IBD intersection, and autoimmune disease related to GI system.
Okay, well, we thank you very much for your time, and we look forward to your bright future. Thanks very much.
Thank you so much.